do is just basically go through, for Ben's sake, because he's not sure of his anatomy, and a little bit of pathologies and a little bit of revision, because I think, I'm not sure how many people are good with their bony points and bony landmarks and stuff and ankles and stuff like that. And then obviously, it's not something I think we do very well here, but it's just develop an understanding how the whole kinetic linking goes, knock on one thing or knock on everywhere else all up the line. And we talk about anatomy trains and things, but the feet is so important to start thinking of everything else above the body, how we go there. And I can see Nadine nodding very careful with this, but it's true.
Get out.
And then so we'll try a few techniques. I was just saying to those who are late that you shouldn't learn anything new, and the techniques will be exactly as you've done them. But I just want people to try them a little bit stronger and see how it affects the techniques by doing them stronger. Because I think we tend to do them with a bit of a Maitland head on us, and really getting into stiff ankle joints really is good. And you might think you do, but maybe you will show you ways of being even stronger. That's good. So, again, teaching you all the suck eggs, we'll just flip through these slides very quickly. Obviously, the way I always look at a foot is very simply in three parts. You've got the three regions of the foot, but if you just talk about it as like paddle, gearbox, and power at the back, I think patients pick it up really nice and easy, because if you're not getting transmission of power from the calf going to the paddle up with the toes at the front, you're kind of stuck in first gear in the mid-tarsals, and usually quite often around the mid-tarsals everything's quite blocked. Yeah? So if you can get out of first gear into fourth, fifth and sixth, then you've got transmission forces between the two, and they get that, because otherwise if you go, well, your mid-cuneiform and your cubical cuneiform is a bit blocked and stuff, it just annoys the hell out of them. So keep it nice and simple, I guess, as we all do. Obviously, Clara John, I think the big key in this slide here is you've got a triangle going into a square. Yeah, so you've got a triangle fitting into a square. It doesn't actually fit. So when you ever get ankle sprains or you get any involvement with talar crural joint, then this fit won't work too well. But it's all reliant upon the distal tib fit spreading to allow this wedge shape to fit in. And I think we possibly deal too quickly with the midfoot and talus without looking at the distal tib fit mobilisation first. But that's open for argument. Does everyone work on distal tib fit first? Almost run the mill. That's what I'm encouraging you to kind of do, because I think without that, you're always going to have a tight square to poke into. And if you think about the conics all the way up, the whole rotation up into the leg all comes really from the distal tib fit. So the spread around there, I think, is really quite important, I think. But we can argue about that in a second. So yeah, sure. Obviously, joint moves posteriorly and superiorly, and anteriorly and inferiorly, glute flexion. And then you've got these angles, and I think the angles are the calcaneus 23 degrees medial, 41 horizontal plane, probably 41 or 41 and a half. But rough angles are pretty quite important, because this is where we should be looking at how we're putting the angles of our pressure when we're trying to improve range of movements as well. And the talus is quite an interesting bone in itself in the sense it hasn't got any muscular attachment. So it's really at the mercy of everything around it. So what goes on in here is also pretty important too, especially with severe pronating feet in an ankle version. So there's a lot of instability, and it's not just ligament support; it's positional support that really the problem. So we as manual therapists, I think we should be trying to get as much mobility and play off that, rather than assuming it would. So see this one shoes right there. Yeah, okay. So the first rate, I think, is possibly where every place to start. I don't know where you would start looking at an assessment.
It varies. I don't always. Sometimes I start the ankle and work distal. Sometimes I start at the first MTPJ or proximal height.
Yeah, and there's no right. I'm sure there's no right. But I do think if your first ray and your lateral ankle aren't moving, then the bits in the middle are very difficult to treat. Yeah, so they need to be cleared first before you kind of work in centre. And I know when you do your foot assessment, it's always about that first ray getting activated first as well. So once you've got mobility, I think it's also about getting strength through here as well. And it's your rigid lever that pushes you off. So let's have a look at someone's foot. One foot. Testing plantar flexion and rotation around the first ray. Obviously we've got various joints to look at it, but around the navicular you've kind of got a tubercle, the navicular, and if you just press behind it, you're going to feel like potentially just by locking in there, the whole soft tissue is kind of lost. There we go. Normal movement. By locking in, suddenly the whole line tissue is quite tight. So actually just by breaking down the simple soft tissue behind you, kind of release that away quite nicely. Then you can go in anteriorly, and you can do the same, but here you've got lots of movement in your foot. Chosen the wrong one, basically.
Oh, we can swap. Do you want to take my shoes off? Yeah, guaranteed. Oh, I'm different.
You see someone like myself, there's not going to be very much movement, yeah? But you're actually quite stiff in behind there. You can see that's quite limiting, but there's no limit at all, no we're fixed here.
So pushing in you feel
just by blocking as we go down,
yeah.
each segment, yeah? And then softly cue there from tarsals, get plate movement. We just work from proximal to distal to try and just release soft tissue. I think just by working on rotation, plantar flexion, dorsiflexion, you can actually break down quite a lot, just melts the tension, scar tissue in this area here. And obviously stretching the plantar fascia is really quite important as well, because in this position here it will actually again affect the first ray quite considerably. So if you go into do you know the knot of a Henry? Yeah.
Knot of the Henry.
Knot of a Henry. Again, I'm trying to fix up. They work the two together. So basically what I'm doing, I'm spreading.
Okay. Did you do any of that?
Yeah. And then knot of Henry is where the flexor digitorum longus and the flexor hallucis longus cross over.
Right.
Because it's like a little knot.
Right.
So it always gets a bit like a ball of wool.
Yes.
Gets tied up a little bit.
Yeah.
So you see the difference between a flexible foot and a loosey foot. So first of all, just look at the difference in flexion. Up here, there's nothing. So if we lock into here, not very good loosey.
No. Ever since I've had my insoles, I used to not move at all. I think that's something you'd find on the bottom of the rocking horse.
So you might want to actually manipulate a stiff joint. So if you manipulate at the joint line, you want a good stranglehold here. And then with this hand, you want to kind of almost go on top of it. Yeah? So the middle finger I tend to use. So just get on top. And so what we want to try and do is we want to layer the fingers over each other. Yeah? So we've got a good strangle grip there. That's not going anywhere, yeah? It is strong. And then layer it to give even more strength. Yeah. You probably then want to invert to find that loose packed sort of joint position. Yeah. You could even invert and dorsiflex a little bit as well if you wanted. Yeah. But then you want a traction to it. Yeah. If you obviously slide, yeah, you're not going to get traction. That's why you need this hand on top to lock on that locks, and then you lock on the lock. Wind up, and then move. Yeah? And then you test it and you do all the sort of self-contained movement. Yeah? Do you guys want to have a play?
Yeah.
Yeah? That's usually someone else's foot. Yeah, you still have.
anything else
Yeah,
after.
I've got it. There's usually a crease in here, which just follows in Baxter's nerve. Now, if Baxter's nerve is irritated and inflamed,
Oh, okay.
then that will be missing.
Well, the crease.
So if they've got a Baxter's nerve obvious, if they've got a crease on one foot and then not on the other, there may actually be some inflammatory problem going on in here.
Okay.
And the thing about Baxter's nerve, you can quite often get Baxter's nerve inflammation pain, which is really close to plantar fascial pain.
Yeah.
So differential diagnosis, you might be thinking, is it one or the other? Yeah. Do you do Baxter's nerve pain?
Yeah, it's a pain in the arse if it's irritated as well. Well, I often find it's they have that alongside plantar fasciitis. Usually the plantar fascia pain will be typically the medial calf tubercle, and then they tell you that the pain is moved, and it's either moved along the arch, the plantar fascia has become further irritated. But actually, you feel quite a bit of pain around the medial calf, and when you feel around that area, they'll be like, yes, it's very painful. How I manage it, I guess it's no really different how I treat plantar fasciitis.
Offloaded.
Yeah, a lot of the time they're going to be excessively pronated, means they're going to be loading the medial calf quite a bit anyway, which is going to compress that nerve a bit further. So I don't really do anything different with it. With Baxter's nerve entrapment, however, it can be difficult to get that, to release it, if you like, without surgically getting involved. So it's quite tricky, actually. That's what's a pain in the arse.
It's more medial pressure pain.
Yeah.
Infra medial pressure pain.
Yeah.
What's the cause?
Entrapment.
Okay.
So the nerve gets caught somewhere.
Do you have a positive interest? Would you
You could bring it on. It's
But
really,
not-
really irritable and
Not always
yeah.
though, yeah.
Yeah, with a little bit of eversion.
With a bit, okay, fine.
So if it's entrapped, so by mobilising, you kind of release it, or?
We can try, yeah. How successful that is.
So sticking on the first ray, we got various pathologies. Obviously, your head abductor valgus you should be looking for is the base of the tarsals, and typical thing will be this Frank's either fracture or dysfunction, and that's very frequently misdiagnosed. And how often do we look for it? Again, I'll challenge everybody here whether we standardly look for this Frank's, and it doesn't have to be a nasty fracture, which will require sort of surgical correction. But if you've got like a forced plantar flexion or a forced dorsiflexion, you're potentially going to get these Frank problems in the foot or something like this. Yeah. So it doesn't have to be dysfunction at the mid-tarsal joints or the ankle or the subtalar that is the original cause. It could well be mid-tarsal. Yeah. So you actually want to feel around in the mid-tarsal areas as well with those sort of mechanisms of interest. And I think we need to quickly assume it's going to be temporal or subtalar. It often is, but yeah, you can have a real mess of displaced fractures.
Oh, God.
And then, the best thing really is to get just get hold of the navicular, and just have a little wiggle really, and then from the navicular find out if each joint. So you can actually even take each toe. Try and maybe a bit dorsiflexion, try and fix. See if there's an excessive amount of movement. Yeah. Obviously, what you find generally is a lot of stiffness, but you just want to listen out for crepitus and that sort of issues around this phase. What else would you look at?
The history would raise my suspicion of that. If they've had a sprain and they've had a sudden forced plantar flexion, and they're getting pain around the area, then that would be one of the first things to be my main concern. And then I'd ask if they've had an X-ray. If not, then it's something you look at. Because gold standard first-line treatment for a Lisfranc fracture is surgical stabilisation with screws.
For fracture,
yeah.
Yeah. For a dislocation or a disruption.
Well, usually there will be a fracture. If there is dislocation, there's probably a fracture to the bone as well. So surgical intervention is going to be the best thing. There's other people have said, you can have it immobilised in the cast and see how it responds, but patients often go on to get long-term complications where it hasn't been stabilised. So I'd
So
just send
that's
for an
like
X-ray.
morning, John. We had a patient who fell down the stairs. He could have easily had something like this in it, but I think his is purely telecoral. But he had that plantar flexion inversion fall.
Yeah. So they're quite rare though. I've only seen less than 5 in my experience.
So obviously we need a wiggle around the 5th ray as well, so we don't miss any sort of mid-tarsal fractures, but probably more commonly is more cuboid subluxation or something like that, especially with some sport if you land quite heavily, hard landings and impacts, that sort of thing. And obviously you've got the strong peroneus longus pulling up on that side as well. It subluxes the whole calcaneum, cuboid subluxes and pushes up, or down, can be either way. And so to manipulate and then pad it can sometimes help. So you want to feel the movement of the cuboid, which we'll do in a second, and let's miss that out. And then look at how we can maybe mobilise the cuboid. So what you've got. Place down. You could do supine. It's not. It doesn't have to be on your back for face down. So again, I'm just going to get onto the keyboard. So first of all, we've done all the fixation of the 5th. Trying to fix that right there and just see what's actually happening. The 5th and the 5th on the 4th. But we assume we've done that. So thumb pressure, and again, a little bit of thumb pressure is not doing very much, so it has to be a lot of thumb pressure, so I'm pushing my whole body weight through there. Yeah. So it's a little bit push on top, and then I lean into it. Okay?
It's normal in some way.
Yeah. Then
It's tender.
it's tender, yeah. So then you want to kind of invert the foot. Okay. So we're just going to invert, and then put lateral pressures inside there. Now, if you try and pull up,
Really?
yeah, put your toes up, yeah, and then plant flex, pull up, okay, and then what we can actually do next stage.
Graham, the only thing I'm a bit confused with that is that the only ones that I've seen, I would call sort of a superior subluxation. So it's like the cuboid comes up.
Yeah, that's the most common because you're landing on it, but if you
Yeah.
get a stiletto onto it, it's a downward one,
Right, okay.
for example.
Okay.
Yeah. What else would you go with?
I don't see them often, to be honest.
I think you see them a lot in gymnastics.
Yeah,
That's
no,
what's
sure.
called.
Well,
Barefoot-
dancers who I've
barefoot
seen.
dan-
And
yeah.
then it's really hard. I
Yeah.
find it very hard to make any difference, really.
I mean, I'm familiar with
I
this
don't say
technique.
anything else.
Yeah, I'm familiar with this technique, and I've done it a few times, and sometimes I get a good result, but sometimes I get no improvement whatsoever. So I find myself scratching my head when I get a cuboid syndrome problem.
So you kind of want to grip around the metatarsal joints, grip strength here, press in, dorsiflex, invert, and then pull. And then once you've tractioned, you traction along the line of the tibia. Yeah. Once you've tractioned, there's going to be a bit of pain. So if you turn it back,
Really?
That doesn't stand still.
I can see your face.
That doesn't stand still.
yeah. What you do then is you then tape. You could use like I've got elastic on up there, which is like a one stretch elastic adhesive bandage, but any sort of elastic or even kinesio tape would do. But you don't want rigid tape because you're then going to affect it. And then just make sure you go behind the 5th metatarsal head
Yeah.
and pull up and maintain it. It's been a cross round.
Okay.
Very simple. Yeah. But then you want to follow up with that for as about 12, 24 hours.
Oh, the benefit.
Yeah.
Yeah.
Anybody want to play the cuboid in the 5th row? Get along?
Since it's already marked.
Shall I leave that with that? Show you what you're doing?
You want to turn over?
It doesn't say it actually is an arch, but what you want to really establish is whether you've got drop metatarsal heads. Right foot, say. Very simple drop metatarsal heads. You should be able to see as you flex, nice and equal. And if one's actually kind of dropped down a bit more, you won't quite see it quite so prominently. Yeah. That's obviously the lazy way of doing it. Yeah. The other way is actually checking on callus and actually looking at the whole foot pump
I
mechanics.
find it a lot easier to see pro, sorry. I find it a lot easier to look at it.
But I find, just as a quick, do I need to look at it in a bit more detail? Oh yeah, that's fine. Yeah, but every foot I do that, just to make sure there's no drop in the tilt or head. And then others that I'm more concerned about, like it's more obvious there, and a big lump of callus on the bottom, then I do it a bit more on a fancy thing. Yeah, let's ignore that. And that. And that. And that. Navicular drop test, quite interesting just to see how people just kind of drop in their navicular, and you can just have a simple piece of paper and a line measure or a proper wedge that goes in, how deep, how far can it go in. They can have all sorts of little tips going on just like that. But it's just a stance. It's not full biomechanics. So if you compare that with your Taylor neutral position and non-weight bearing position, it's going to be very different. But you need to note, I think, if you just stand again with Lucy, you stand facing us all here, face to face the crowd, and just cross your arms with your feet nice and comfortable. Well, separate a little bit. Just shoulders. Okay, you want to see what sort of navicular raise is there, a navicular raise and drop, or is it very stiff on one side? And this is how we're looking at the whole kinetics all the way up. Yeah? I think this gives you a lot of information just looking at this way, and then if you just turn around and do the same thing. And then again we can just see what's happening, inversion, eversion, calcaneal. So a little bit more dynamic than just the standard look at seeing people walking and seeing people. And you could do this on one leg as well. There's another thing to go for. But if they invert, very, very commonly there's compensation. If you've got an inverted rear foot, like I'm that particularly, I've got very limited dorsiflexion and I invert. So there's always going to be a compensation somewhere else. And so for me, it's kind of the tailor-crural joint. Or potentially in the knee, which they do have surgery on against the knee. So again, maybe the fact that I'm constantly in the inverted position, it just locks everything further up. So you want to unlock that inversion position. So not always that's just your posture. You want to compare it with the other side and also how it feels as well. And I think we always go, well, that's your body type. If you're inverted rear foot. That's you. If you're early pronator or late pronator, that's just you. I think we've got to look further than that. I'm sure you'll agree with this. So not everyone's a certain foot type alone. They may have made themselves a certain foot type by being imbalanced and stiff in certain areas, which is what we're working on today. So we know all this. Subtalar neutral, so we won't talk about it. Calcaneal stance, again, we won't talk about it. But we want to look at how people squat. So again, Lucy, if you just want to squat for everybody. Yeah, are you as hopeless as that person there? But go down a little further if you can, wider stance maybe. Yeah, no, keep your chest up. Oh, come on, Lucy, don't put squat. Okay, so is there any knees coming in? Yeah, I'm a good example of this, I'm rubbish at it. Yeah, so when I'm going down, this knee wants to come in further. Yeah, so I need to we can rotate and strengthen the glutes, but is it because of the foot posture? We'll do this obviously in bare feet. But again, I think systematically look at squats, and we're going to get Michaela Breeze coming in to teach us how to do a proper Olympic squat, and she's actually going to go through foot position, back position, hip position, knee position as well. She's lifting lots of kilos, but if you don't get the basics right, what's going to happen? So that's a great squat. It's just always coupling going up and down the body. Distal fib joint, distal tib fib. You actually want to assess it just by grasping it and wiggling it around a little bit and trying to find it, but you actually want to treat it as well. So again, if I come up, so the common problem would be if you're lacking a little bit of dorsiflexion, it's often because this is not opening up, not always, obviously, it's often the crural joint itself, the subtalar joint below. But A big factor might well be distal tib fib, so we want to just basically just go up and down, just sort of feel how much movement and compare it to the other side. That's right. So you can do it both more closed joint position and again in open. Yeah. I'll do this very, very quickly, so I'm not really accurate. But I think to try and improve that, if you find one side stiffer than the other, place where I always like to start, you also want to pick up the anterior tibialis. Yeah, so you want to go above the ankle joint. You don't want to be on the lateral malleolus because that's usually always quite painful. This isn't pain-free either, though. Yeah. And then again, is you just want to put full body weight. So I've got a straight arm, picking up, and then trying to mobilise. And I've got somebody here which has got a nice bit of mobility. We're going straight into the bed, so I think it's best to kind of hook the heel. And now we can feel it's very, very solid. But that's a lot more than what I see an awful lot of, which is just that. Yeah, you can see the knee effects and everything that goes elsewhere. So here is very sort of, again, much more positive sort of grip. Like, okay, no knee movement, pure distal tib fib. And if you just go on the tib fib, you'll slide off the anterior tibialis. So I'd like to kind of just get in there first and have a go. Quick like that. Cool. Do you want to do that with something else? Ankle impingement. And what's going to cause ankle impingement? It's usually the position of the talus sitting in the mortise.
So I'm going to put it into there. Otherwise I can't get just purely that.
Okay, so who's got stiff ankle? Anyone here got a stiff ankle? So if you sprain this ankle, cool. Yeah. Okay. So if you come this way, right in. Okay. So if we, not too bad actually, but if we put some pressure on the talus, what we want to see is we want to be able to fully dorsiflex here, and just try and fully dorsiflex here, and as we push in, we should be able to get 90-degree knee flexion quite comfortably before it kind of locks, yeah? Or even further if we can go. Yeah? Somebody who's stiff, I don't want to say this ankle is stiff. Yeah, you might be stopping here. Okay? So again, we just dorsiflex. And you're right, I can't get there. You see the difference? So I'm blocked there. So what we want to do is we want to try and mobilise this. The way we can do that is distract it. So I'm going to turn my back to you, Martina. Right. Good leg position, because you're going to fix with your hand. And your hand needs to rest against something. So the hand needs to rest against something so you've got a good grip of the ankle here. And then web space right onto the talus, dorsiflex. And what I'm going to do is I'm going to go downward pressure. Quite strong pressure? Yep. Yeah. And then I want you to kick forwards, okay? Yep. Rather than kick, probably just extend, yeah? So 1 second. And again, kick forwards.
In a lot of other societies, it
And
would
relax.
be abuse, wouldn't it? Yeah.
And again.
Thank you.
And relax. And how much pressure am I putting through?
Yeah, quite a bit.
Yeah, I'm sweating.
It's a struggle for me.
Yeah. This is my point. If you're trying to open this joint up, I'm going to put a lot of pressure through here. And that is hurting my web space, yeah? But then we measure again. That's more movement. Yeah? You want to go? Yep. I'm really rushing through all these slides here, but with posterior ankle positioning, obviously there's loads of different things you can have. You can have os trigonum, you can have problems with the flexor lucis longus, you could even have a cabinet being fracture, but not so common. and then obviously Achilles tendonitis and those sort of things. We won't bother with that, and we won't bother with that other than knowing where it is and what it involves in. How often do you see those? Osteogones, sorry.
Osteogones?
Not completely rare, are they? But
No, a lot of people have them and they're asymptomatic.
So sometimes there's a lot of posterior impingement that isn't osteogone, but you just work getting an X-ray to find out what it is, because you're fighting against a bony lump otherwise. Calcaneal belt fractures again from strong pull of the Achilles. Yeah, again, you might want to look at a choke grip to what time for this? Yeah, let's do it. So calcaneal facet, I think, is quite good. Oh, yeah. So face down.
You wait.
So you want to stabilise the thigh to the bed. So the best way is just to kneel on it. Yeah, obviously not kneel on it, but you want to kind of keep it nice and fixed. And this will kind of waft around as well. So you always want to flex the knee into your leg. Yeah, so that's not going anywhere now, Kelly. Hopefully. All right, and then so with your anterior hand, you want to choke hold around the tail and neck. Okay, and so that's quite a strong choke hold. Yeah, you okay with that?
Yeah.
All right, and then place your hand superior aspect of the calcaneus, and it's all about the elbows. If your elbows are all over the place, you're not going to get the brain here, so you want the elbows. Good choke hold, and this depends on the degrees, 25 to 40, 42 degrees, it could be anywhere between there, with near 42 is where it should be, but might only be 25 with some tight angles. So you go with where it is, but your elbows have to be at that 25 or 42, yeah? And so actually what I'm going to now do is just squeeze my hands together, yeah? Sorry. So you've got a strong choke hold, superior calcaneus, squeeze your hands together. And the manipulation is obviously a shove through the arm with the watch on. Yeah, so we're going to go that way. Yeah. So you cause a little bit of traction as well.
Yep.
Push, and then manipulation. Now obviously you haven't got a problem, but if you're quite stiff there, you'll feel that will give and it will go. Yeah. And again, that's a little bit of a forgotten joint. Arm posterior impingement pain. So again, it's maybe worth a little go at that. Sorry. So just hang on. It's good. So come around and see that. There's so many people do different things, and a lot of people just kind of. But your fingers kind of buckle. Yeah. So it's really difficult to try and keep that, and you always like want to try and overload it and then keep doing it, and you get a little, not very dainty either, but a little more perception is to actually use a wide leg stance. So what I'm going to do, and so really be comfortable. So again, get around the talus with the web space. And now I'm going into this position. But now I can actually put, again, very straight arms, full body weight into this area here. Yeah? Okay? Yes. Strong, yeah?
Yes.
And now, what do we get you to do? We get you to squat.
Oh, again.
Yeah, you can just go bounce around on it.
Oh, that's much better with that grip.
Yeah?
Is that very good?
Yeah,
That's really nice.
Yeah.
Very nice.
But then you can also abduct the tailor. AB duct. Yeah, so we can come in from a little bit of
See,
that. Yeah? And do something. That again. Yeah. Or the other way. But yeah, you choose the appropriate client, because if you've got a really stiff ankle and you want to try and move it, I mean, even with you there, you probably want to grasp the calcaneus quite firmly and really work at mobilising not just the calcaneus on the talus, but midfoot to calcaneus too. I don't think we do enough cuboid and unicular calcaneal mobilisations. And the other big thing, I think, which is really good, is I think we assess people who out of their footwear quite a lot, but we really want to assess people in their footwear as well, and not just when they're running, but a lot of the footwear, if you just chuck it on the floor, it will continue to rot. Yeah? And if you've got that much instability, you're really asking for trouble. And whether you believe in orthotics or not, it's just a button of air you're standing on. Yeah? So shoes can be really useless. So, I mean, what do you think then, with someone on shoes like that?
Yeah, they need new shoes. Yeah, they're just worn down, some shoes unstable. If I go stick an orthotic in an unstable shoe, the orthotic's unstable, the patient remains unstable. So I've spent a lot of time talking about new shoes or getting their heels renewed so they're square. Lateral heel wear is the most common thing to see. Don't often see people with excessive medial heel wear, except for really early pronators. 9 times out of 10 they're going to be a lateral heel strike.
And shoes like this? So to me, they're not so bad as these, in a way, because the only problem is if you've got anterior and posterior shift in the shoe. But if you don't need a lot of stability, are they bad? But generally, yeah,
I'm not worried about their toes being a bit vulnerable.
well, you go around in flip-flops, it's the same thing.
Yeah, that's right.
What were the rest of the clothes like?
Yeah.
It's like that.
I've got a 2 o'clock flight.
Yeah.
So
Graham, thank you very much.
Yeah.